So good morning, good afternoon, and good evening, everybody. To all our webinar participants, my name is Tanya Hoch, and I am the head of the Dräger Academy here in South Africa. I would like to welcome you to our webinar conducted by Dr. Yasin this evening. We are happy that Dr. Jule has agreed to share valuable information about his experiences and advice on clinical application of high frequency oscillation. So just a disclaimer that I would like to go through before doing the introduction of Dr. Jule. So the following presentation is a recording of the presentation titled Dräger South Africa, Challenges of High Frequency Oscillation on the 24th of June 2021, which is a Dräger organized and hosted educational event on the topic of high frequency oscillation using the BabyLog VN family. The author of the presentation has permitted Dräger to share this information with you. We explicitly wish to inform you that this recording is purely for informational and educational purposes. Dräger had no influence on the presentation content, nor did Dräger take any editorial measures regarding the content of this presentation. The sole responsibility with regard to the contents of the video lies with the author. All views expressed or information given are not linked to Dräger and were not censored or altered in any way. So with that being said, I would just like to do an introduction to Dr. Yasin Jule. So Dr. Yasin Jule is a pediatrician with subspecialty qualification in neonatal medicine, but remains interested in all aspects of pediatrics. He is currently a consultant neonatologist at Groote Schuur Hospital, a tertiary academic hospital in Cape Town, South Africa. Dr. Jule is also a senior lecturer in the Department of Pediatrics at the University of Cape Town and is a caring, patient-centered doctor providing affordable quality healthcare. Dr. Jule, in addition to the above, has published numerous papers on various topics related to premature infants in the NICU environment. His special interests are infant nutrition, growth and development, care of the preterm infant, quality measures, improvement strategies, and patient-centered care, and appropriate technology application in the NICU. Before I do hand over to Dr. Jule, I would just like to go through the webinar toolbox and how everything will work during the course of the webinar. So on the right-hand side of your screen, you will see that you have your webinar toolbox. By using, I just want to grab the laser pointer. So by using this orange arrow, you can then minimize or maximize the toolbox on the right-hand side of your screen. So you will see that you will be muted throughout the webinar, and any questions, comments, suggestions, etc. that you may want to put forward to Dr. Jule should then be please typed into the question box. So the question box is the gray area that can be seen below. And to open the question box, you can just click on this little square icon with the arrow, and that will open the question box that you see on the right-hand side there. You then enter your question, and once your question is entered, you send it. The questions will be answered at the end of the session, and I will read the questions to Dr. Jule for him to be able to provide your answers. So I would just like to ask if you could please use the raise your hand icon that I can just make sure that all the attendees that are currently dialed in can actually hear me loud and clear. So if you could just use that little raise your hand icon in the toolbox, then I can just get confirmation that you can actually hear us. Right, I do see the hands going up. Thank you very much for that confirmation. You can put your hand back down. I have gained the confirmation, my apologies, that I do need. All right, so before handing over to Dr. Jule, I must offer our sincerest apologies for having to change this webinar from last week Thursday to this week Thursday. Unfortunately, both my colleague and I were down with COVID-19 and were not very well at the time, so we elected to just postpone the workshop to today. Unfortunately, due to us having been in isolation, etc., we will not be able to do the practical demonstration after Dr. Jule's presentation. So we ask that in the feedback that you will feedback survey that you will receive once the webinar has closed off, there will be a feedback survey, and we please ask you to indicate if you would still like a practical demonstration, a virtual practical demonstration using the BabyLog family, and then pending on the response to this in the feedback survey, we will then organize a virtual practical demonstration using the BabyLog in high frequency oscillation at a later point once we are all back at the office and healthy. So again, we do apologize for this unfortunate occurrence, and we will try our best to schedule another webinar where we do the practical portion if it is required by the participants. Again, please indicate this in the feedback survey after the webinar. All right, so with that all being said, I'm going to now hand over to Dr. Jule, and he will then take over the presentation.
Hi, Tanya. Thank you so much for the introduction.
Hi, Dr. Jule.
Okay, let me just share. And okay, here we go. All right. So again, thanks for the introduction and for the invitation to present this webinar. You know, it's a topic that, as a junior doctor, I really actually struggled with understanding the power of this particular tool of high frequency oscillation. And you know, as I grew up in the NICU, my understanding changed, and especially now with the advances in the technologies that we've got, I've actually learned quite a lot, and I actually lead a lot of the teaching from our side regarding this. And you know, it's an absolute pleasure to just share this information with you. If you're anything like me, you know, this particular mode of ventilation has been one of those mystic things that we do, and many often don't actually know how it works. And I can say in the early parts of my career, I was in that same boat, and I was looking for a simple explanation. How does HFO work? And the people around me, actually, they struggled to explain it to me. So when I used to ask, how does HFO work? I get answers like, no one really knows. It's magic, or it just does, or it's like a washing machine. It washes out the carbon dioxide. So, you know, with that, you know, I just want to start off with this quote from Arthur C. Clarke: "Any sufficiently advanced technology is indistinguishable from magic." And I want to try and demystify this for us because my first encounter with an oscillator almost 18 years ago now, on my first day working in the NICU, we were struggling with a baby that was preterm and had severe respiratory stress, and the consultant said to us in Afrikaans, "Gaan haal die ossie." In English, "Go fetch the oscillator." And I didn't know what that meant, right? But in rolls one of the registrars with this machine, and I'd never seen this before, and it looked to me like something out of a Buck Rogers TV show. And the irony is that these days the device look a lot like 80s TV sci-fi robots, but they really are starting to become really smart, and they offer multiple modes of ventilation, conventional ventilation, and then with a touch of a button, you can switch to high frequency oscillation, which you don't have to roll in a different device anymore. And then on top of that, the devices now, they provide feedback to the clinician. They allow us to tailor the therapy to the patient. And now they even they push that one step further by building intelligence into these devices. They allow them to monitor what they deliver and then allow the device to actually self-regulate its own performance. And if that doesn't sound like the future, I don't know what is. Of course, you can't have everything, right? So in this package, there's some sacrifices that to be made. So these devices are not as powerful as the older or earlier devices were, but that power is superfluous for the neonatal application. And you don't really need a V12 engine in your car to drive in a highway where you can only go 120 kilometers, right? The power is superfluous. What you get is a blend of different smart applications in these devices that make up for that loss in power significantly. So these are really smart devices now. So why should we use HFO? How does HFO work? What parameters do we use to control it? And when should we use it? These are the questions that I'm trying to demystify for us over the next hour. So I hope you can all just bear with me. Right, so why do we use it? Well, the only reason we ventilate infants is to try and save their lives. But we've known for a while now that when you try and ventilate an infant and you do it with really high pressures and really high volumes, you end up with lungs that are destroyed. And in the preterm baby, that means bronchopulmonary dysplasia. So we've known for a while, even before this 1967 seminal paper that first named BPD. But now, what causes BPD? Well, it's not just ventilators, right? The preterm infant has a setup for that makes him ripe for BPD. In that he's in the embryonic phase of his development or her development, and they're born preterm, and they are exposures to different issues like cytokines and glucocorticoids, and then of course you take them out of the womb, and you don't have enough nutrition, and you give them lots of oxygen, so there's oxygen toxicity, and then on top of it there's surfactant deficiency, and the chest is very extremely compliant, and the lungs just don't have enough architecture to it. And then you add a ventilator to it, and these lungs cannot alveolate further in the way they normally would have in utero, and you end up with bronchopulmonary dysplasia. So the ventilator part of this is what we're trying to mitigate, right? Because ventilators, we know, have lots of iatrogenic effects. There's oxygen toxicity, barotrauma, rheotrauma, which refers to the flow of air that can cause issues in the lung. And then the big things which we can do something about if we use the correct strategies are atelectrauma and volutrauma. So volutrauma, managing our tidal volumes very appropriately so that we can reduce any stress from volutrauma, and all of this can lead to effects outside the lung with multi-organ involvement as a result of endotoxin leakage into the bloodstream, bacterial translocation. All this ends up very poorly for the infant. And so we're really trying and develop strategies that can mitigate this part of the care that we offer infants, right? So here's the challenge, right? We need to we need to get air into our lungs, and we need to get that air all the way down into the alveoli, and we need for the gaseous exchange to occur into the pulmonary blood flow in order for us to survive, right? So in newborn lungs, we've already talked about how they're prone to ventilator-induced lung injury and that they're still developing. But the other issue with newborn lungs is that there is so much dead space in newborn lungs of about 4.5 to 5 moles per kilo, and then you add that to the functional dead space. Now these are alveoli that are not that don't really have much pulmonary blood flow, and so whatever air goes into them, there's no gaseous exchange occurring. So when you add all of that up, you've got about 5 moles per kilo of dead space in the lung, all right? So it makes sense then that when we do conventional ventilation, that we're aiming for tidal volumes of between 4 and 6 moles per kilo, right? And in the concepts that we taught in normal respiratory physiology is that the size of each breath, the tidal volume, must exceed that volume, that dead space volume in the conducting airways in order for us to inflate the alveoli and in order us to get gaseous exchange. But now again, as I mentioned before, if the tidal volumes are too big, we risk volutrauma. And if they're too small, then, well, that can lead to atelectasis. So, there's a fine balance, and that fine balance in conventional ventilation, we've more or less got down to about 4 to 6 moles per kilogram in the neonate. Here's the mind-blowing moment, okay? When we do high-frequency oscillation ventilation, the tidal volumes that we are using are less than the anatomical dead space volume. We're talking about tidal volumes of between 1.5 to 3.5 moles per kilogram. And on top of that, when we're giving high frequency oscillation, we're not giving breaths at 60 to 70 times per minute. We're giving high volume, high frequency breaths at about generally between 400 to 1,200 cycles per minute. That's the frequency of these little volumes of breath that's going into these lungs. And then the other thing about HFO is that each phase of that cycle, the inspiratory phase and the expiratory phase, are active phases. In comparison with conventional ventilation, where you have the active phase essentially only being the inspiratory phase and the expiratory phase being a passive phase. So, yeah, this is essentially the definition of high frequency oscillation ventilation. So where did it come from? So this guy named Henderson in 1915 was looking at dogs panting and thought, well, they're breathing so quickly and so fast and they're so shallow. How is it possible that they can actually be getting any air into their lungs? How are they still alive? So he designed an experiment to find out. And what he did was he took a long glass tube and he smoked a bunch of cigarettes. And then he blew smoke down that glass tube in shallow, short breaths. And he noticed how the smoke formed a thin puff of smoke, essentially down the length of the tube, with a little point at the end, right? And then he's noticed that the quicker the puff, the thinner and the sharper the spike. And then he used his tongue to seal off the tube, and he noticed that the spike broke instantly, and basically you had a mixture of smoke and air uniformly diffused into the entire tube. And then the reverse of that happened when he sucked in fresh air. So he suggested that during each of these high frequency small breaths, there was a parabolic core of fresh gas that penetrated deep into the lung and reached the alveoli. And although his hypothesis was not entirely correct, what he did was he started the debate on dead space ventilation. And he didn't invent high frequency oscillation. Maybe if he smoked fast enough, he might have, but he didn't. But the conversation got started. So how does this, where does this all come from, right? So let's go back to conventional ventilation, just to get a basis for what we're talking about. We talk about time constants in conventional ventilation. It's the time that it takes for volume and pressure to take a stepwise equalization between the alveoli and the airways. Now, obviously, the stiffer the lungs, the shorter this time constant will be, right? And it takes about 5 time constants for you to get about a 99% equalization in pressure between the alveoli and the airways. So during conventional ventilation, the time required for gas to travel from the one end of the airway depends on the ventilator's peak inspiratory pressure, the inspiratory gas flow, that's this little bit over here, and the pressure flow waveforms, which also has to do with the compliance of the system and the resistance of the system. But essentially, after 99% pressure, or rather after time constants, there is 5 time constants, there is 99% pressure equilibrization between the proximal airways and the terminal airways. And you find that flow stops. Okay. So during expiration, the time required for lung emptying, which is a passive process, depends mainly on the lung and the chest wall elastic recoil and the expiratory resistance, and of course the amount of PEEP that you send. Okay. So it's if the time set for the inspirations or the expirations are long enough, the gas flow stops. That's what we see here. Okay. The key factors in developing, producing ventilation in conventional ventilation is the pressure, the time, and the flow. Okay. I hope you understand that, because it's a very important concept, because when we go further, you'll see that when you start to increase your respiratory rate, your I time and your E time, rather your inspiratory time and your expiratory time start to decrease, because there's less time now to give the inspiration and the expiration. Okay. Eventually, no pressure equilibration occurs, because now there just isn't enough time for that pressure to equalize and no flow to occur. And the flow actually becomes just continuous and dynamic. And if you decrease your inspiratory time to less than 3 time constants, there's also a pressure gradient that develops between the proximal and the terminal airways. Okay. So what happens is the tidal volume that we then deliver becomes a function of that pressure gradient. And when you have an increased pressure gradient, you have basically less volume delivered to the terminal airway. So the magic here is about the frequency, right? About the I times and the E times. And I want you to remember this, because the frequency is actually is very important. And we're going to be talking a lot about time constants and frequency going forward. So what you get in HFOV is basically small tidal volume breaths that's rapidly delivered, and which creates a constant dynamic airflow in the lungs that enable gaseous exchange. And this is kind of what it looks like, right? So you get basically 3 zones of the lung that's where the flow occurs. On the top flow, or the proximal rather, airways, you get the flow is mostly by convection, but there's lots of turbulence in the lung. Then when you reach the middle zones, there's still convection, but the velocity profiles of the convection is asymmetric, and there's flow returning, and it's all quite mixed up essentially. And then you start getting diffusion. And there's also different other mechanisms of flow. You get laminar flow that occurs, you get pendular flow, and you get collateral ventilation that occurs. The upshot is you get mixing of air in the lower terminal, in the terminal alveoli, that is not not as a result of bulk airflow, but rather of all of these different major gas transport mechanisms. There's also cardiogenic mixing, which is basically the heart pumping right next to the lung and causing some mixing to occur. And yeah, it's all of these together that cause the air to move, or the gas particles to move from the proximal airway right down into the terminal alveoli. And that's called, it's basically called augmented mixing of gas. The net result is that fresh gas reaches the alveoli. And ultimately, the better mixing of gas in diseased lungs improves the gas exchange, and that's basically the usefulness of high frequency ventilation. So infants with respiratory distress may have problems with surfactant and predispose some of the lung units to collapse. And in conventional ventilation, this collapse and stress placed on lungs when the units are repetitively opened and closed. Hopefully that can play. There we go. Open and closed during each tidal ventilation basically causes shear stress and other iatrogenic injury. And basically, if you're unable to keep these alveoli open, the repeated stress essentially can cause all those issues of ventilator-induced lung injury, which we mentioned earlier. But when we look at high frequency oscillation, the major advantage of high frequency oscillation over conventional ventilation is that, well, that it can distribute the ventilation more uniformly. But as you can see in this video, the lung units don't collapse now. They remain open, and essentially they don't collapse with this expiration, and they don't over expand either. So you have less of a chance of ventilator-induced lung injury from volume trauma and atolook trauma with high-frequency ventilation. So that's the why and the how. Now to deal with what variables can we use to control high-frequency oscillation. And you all may be aware already of these variables. You may have been using high-frequency oscillation. Essentially, there's mean airway pressure, which you can affect. There's the amplitude, or otherwise known as the delta P. There's the frequency, which is measured in hertz, and the inspiratory and expiratory ratio. Now, the carbon dioxide exchange is mainly affected by the adjustment of amplitude, frequency, and IEE ratio, whereas the oxygenation is mainly affected by the adjustment of your mean airway pressure. And what we see here is we've got, this is essentially high frequency oscillation. You've got a pressure, and you've got time, and you've got amplitude, right? And you've got oscillation around a mean airway pressure over a set time, which is affected by your frequency and your IE ratio. And we'll be talking about that as we go in. And all of this is in order to develop a high frequency tidal volume. And high frequency tidal volume delivery in HFOV is an interplay of patient and machine factors that are clinician modifiable factors that determine this tidal volume. And the three biggest clinician modifiable tidal factors are the amplitude, the frequency, and the IE ratio. But there are also patient factors, and the patient factors are the compliance of that infant's lung, and circuit factors as well, resistance in the circuit and the tube, and resistance in the airways, that all affect the amount of tidal volume that is being created by the machine. Now, how the clinician can modify these tidal volumes are essentially by adjusting the amplitude, and that's the principal modifiable parameter for tidal volume. The other thing is that the tidal volume is required to produce effective gas exchange depends very much on the frequency. So you have to choose your frequency very carefully along with your amplitude in order to get small tidal volumes that don't cause lung injury, but still allow you to have gaseous exchange. And you can see in this graph that the amplitude has a direct correlation to tidal volume. So let's talk about amplitude, or delta P. Now, the pressure amplitude that's measured at the airway opening. I just need to collapse this a little bit. Excuse me, it's just some gremlins that has crept in there for a second. Okay, we were talking about amplitude, right? I wanted to get rid of that panel. There we go. Okay. Okay, we're back. So, as I was saying, the pressure amplitude that one measures at the airway opening is dampened as it moves down the airways into the alveoli. And we may have noticed this in a previous slide, but I'll show it to you again. So this graphic shows the pressure on this side and time on that side, and the black line is conventional ventilation. So in conventional ventilation, if you set pressures of say 20 over whatever, 5, you're setting 5, there is enough time for that entire pressure to be transmitted down the large airways and into the alveoli at the same peak pressure that you set. But with oscillation, the amplitude that you set and measure right here at the airway opening is not delivered in its entirety to the alveoli. Damping occurs. Okay. So at conventional breathing rates, that sufficient time is there, but because of those short inspiratory times, there just isn't enough time, and so that kind of protects the lung against these large oscillations that we see, right? That time factor, okay? But things are a little bit different when the lungs have low compliance. So this bottom three show a situation with low compliance. Now in an infant with sick lungs, in order to get the kind of gaseous exchange that you want, you may want to turn up the pressures, and that pressure in conventional ventilation is again transmitted all the way down the alveoli. Now in oscillation, that is still there's still damping occurs, but in sicker lungs, damping is occurring at a less of a percentage dampening rather. So although you may want to use higher tidal volumes higher amplitudes in these patients, you must just always remember that amplitude can cause some effects lower down. So in situations with low compliance, you'll need the high amplitudes to generate that tidal volume that you want in a normal lung. But in situations with high peripheral resistance, so where there's also the damping effect that's impeded to this to the situation, we find that the higher pressures is dampened less, and so you can cause some volutrauma from this. So you have to be very judicious about what tidal volume, what amplitudes that you use. So it's because of the potential risk of barotrauma. Okay, so these concepts are actually quite important, especially in lungs that are not homogeneous, right? Because in inhomogeneous lungs, there's still some questions. So if we look at this picture, which we've seen previously, and look at the green arrow, there's a little bit of a narrowing here in the airway. And what we see is that this resistance might protect the alveoli from the amplitude, but what it doesn't do, it doesn't protect alveola that's more proximal. So you have to remember that there's a coexistence of areas with different compliances and resistance in lungs that are not homogeneously ill. So you have to be very careful about what amplitudes you use because of the risk of barotrauma. Now, if you look at the purple arrows, the areas with short time constants, the sick areas, and then there's areas with long time constants, less sick areas, and they can be right next to each other. So the areas with a short time constant will experience less damping versus the areas with the long time constants. So this is a bit of a catch-22 here, because although the oscillatory pressure in the low compliant lung zones increases the risk of barotrauma here, it may also promote recruitment. So you know there's a bit of a fine balance that one has to get in terms of what amplitudes that you want to use. The other problem with amplitude is if you're comparing devices, amplitude is very device dependent, and it's variable. You cannot actually use amplitude as an indicator of its patient condition, right? So you can't say, well, this patient's on a low amplitude or high amplitude, he must be sick, or the patient must be better, because you can't. Using that raw number it doesn't really help. So so we always have patients on the ventilator and they say, oh, he's on a high amplitude. it must be quite sick. Actually, you can't really say that, because there's a lot of things that might be impacting the oscillation of that patient, that requires that patient to have a high amplitude. And one of them might be the tube is too small, or there's lots of secretions in the tube. So it prevents using it as an indicator of the patient condition. The next variable that we can control to control our tidal volumes in oscillation is frequency, right? So oscillatory frequency is a parameter that's measured in hertz. And so if you have 10 hertz, you have 600 cycles in a minute. If it's a hertz of 15, that means 15 cycles per second. So you got 900 in a minute. Now, if you look at the top axis, the frequency shows the oscillatory, or rather the frequency influences the oscillatory volume. As the frequency decreases, the tidal volume actually increases. Now, in order to get tidal volumes that requires for effective gaseous exchange, you need to look at your frequencies, and the higher the frequency, as I mentioned, the smaller the tidal volumes that you require for effective gaseous exchange. So if you have frequencies of 5 hertz, if you're using low frequencies, you're going to use high tidal volumes. If you're going to use high frequencies, then you're going to use lower tidal volumes to effectively eliminate carbon dioxide. Now, again, as I mentioned before, it's all about the time constant, right? And so when you have a lower frequency, you have more time for your oscillations to reach the alveoli. So the lower your frequency, the more time there is, and the less damping occurs. Okay. So this is important because although the absolute delta P that you may apply at the airway opening, in other words, if you apply a delta P of 35 in a high frequency, those alveoli are going to be protected because of the high frequency. But if you apply a smaller delta P of less than 35, you can see relatively, if you have a high frequency, a lower frequency, those alveoli will be less protected. So the trick here is to use the highest frequency you can in order to have the lowest tidal volumes. Next is the IEE ratio, which you can also affect as one of the clinician adjustable variables. That's the inspiration to expiration. And it essentially refers to the shape of the pressure waveform around this mean airway pressure. So if you have ratios of 1:1, you're looking at an equal inspiration and an equal to expiration, right? Okay. Things change if you go for 1:2. So then your inspiration will be twice as high as your in terms of pressure, and as opposed to your expiration, because your expiration now has to get the same volume of air out, but it's got twice as long to do it. Now, this is how your I timed or your IE ratio actually works in a practical example. Let's say an example where you set a frequency of 10 hertz, right? In this frequency, your cycle time is 100 milliseconds because you've got 600 cycles per minute. So each cycle is 100 milliseconds. In your IE ratio of 1:1, that will be 50 milliseconds for inspiration and 50 milliseconds for expiration. But if you change it to 1:2, suddenly your I time is reduced to 33 milliseconds and your expiration is increased to 67 milliseconds. So if your I time is reduced, that means your tidal volume that you produce will also be affected, because now there's a shorter time to deliver this tidal volume. And so if we look at this graph again of different frequencies and different IE ratios at frequencies of 15 hertz with IE ratios of 1:2 versus 1:1, there isn't very much difference in your tidal volumes. But as soon as you increase or rather decrease your frequency and change your IE ratios, you suddenly get quite a big difference in your tidal volumes. So what is the right IE ratio? So essentially you'll get more power out of the ventilator at a similar delta P with ratios of 1:1. You'll get bigger tidal volumes. But if you're concerned about gas trapping in a patient, perhaps you might want to use shorter IE ratios. And this is less of a problem with the modern ventilators because they use active expiration. But if it is a clinical problem that you observe, then you might want to use ratios of 1:2. But if you want to get the most power out, you use ratios of 1:1. The other thing is that when we're talking about the I times and lung disease, the time it takes depends on the disease state. So for instance, the time it takes for a tidal volume to reach the plateau is significantly shortened in conditions where there's low lung compliance, right? So this is a situation where you might have low lung compliance and high airway resistance, such as Highland-Bimmer disease. You'll find that the patient plateaus in terms of the tidal volume you're able to achieve at a much smaller tidal volume than compared to a higher or rather a healthy lung, right? So in theory, one would use shorter I times, which can be achieved with higher frequencies or a shorter percentage inspiratory time. Okay, right. So that was hertz, frequency, amplitude, and I think for many people, you all knew all about that. That's old news, right? But here is the new kid on the block. His name is the coefficient of gas transport. Okay, we're going to call him by his gangster name, which is DCO2. So DCO2, he's been around all the time, right? He's kept a low profile because we couldn't really measure it before, but it's actually an under-recognized variable in high frequency oscillation. It's critical to the efficiency of gas mixing and of carbon dioxide removal, and essentially the success of high frequency oscillation. And it's measured it's a measured variable calculated from flow and tidal volume monitoring, right? Now, here's the trick about DCO2. There's a approximate correlation to carbon dioxide elimination with your DCO2. The higher your DCO2, the lower the PaCO2. Now, it's not a number that you can just set on your ventilator. You can't say, right, turn up the DCO2. It's not like that. It's a measured variable, and it's measured as a result of, the formula to measure it comes from multiplying your frequency by your tidal volume squared. And see, when you're using conventional ventilation, the amount of carbon dioxide washed out is dependent on your alveolar minute ventilation, which is of course dependent on your alveolar tidal volume and respiratory rate. But in HFLV, things are different. You can't just do that. You start speeding up the rate to more than 300, and study shows there's a completely different relationship between the ventilation rates and tidal volumes. So that's where DCO2 comes in. That relationship that we found here between frequency and square of the tidal volume is, it correlates very nicely with the PCO2. So DCO2 changes exponentially with an increase of tidal volume. And you can see that obviously because if you change your tidal volume and square it, it's going to increase your DCO2. So for example, a 10 or 20% increase in your tidal volume will increase your DCO2 by 21 or 40%, more or less. So the higher your tidal volume, your higher DCO2. But when it comes to frequency, that relationship is linear. In other words, it's because tidal volume is squared here and frequency is not squared. The relationship between DCO2 and frequency is linear. How do you use DCO2? So DCO2 is a measure that we can target, right? And if you calculate it relative to the square of the body weight, it's been shown that if you look at between 50 and 60 moles squared per second per kilogram, it's a reliable indicator or predictor of your carbon dioxide measurement. Now, this is a lot to take in, and we're going to talk a bit more about this later, but I just wanted to introduce the concept here because all this has got to do with tidal volume. The next variable that we can affect in our oscillation is mean airway pressure. And we've been talking a lot about carbon dioxide change, but now this is about oxygenation. And this is achieved by changing the lungs, basically, intrapulmonary pressure by increasing the mean airway pressure. And it's the primary determinant of the distending lung volume, which essentially influences not only how much oxygen gets delivered to the alveoli, but also how much gets taken up by the pulmonary vasculature, because the higher your mean airway pressure, to a point, your pulmonary vascular resistance also drops, which gives you better blood flow through your pulmonary vasculature. So this means that in order to oxygenate, you have to titrate your mean airway pressure. Now, what makes HFO so useful in infants with RTS is ability to use high mean airway pressures, right? Relatively safe to open those lungs and keep the lungs open. And you've all seen these graphs before. So let me just talk you through it quickly. This is a pressure volume curve, and this is basically the relationship in a single alveolus. So if you're ventilating a single alveolus, that alveolus remains collapsed, remains closed right up to point B, which is the opening pressure. And then suddenly that alveolus opens up and will continue to open up as you increase the pressure. But this stepwise opening up is immediate. It just sort of opens up, and then you've got a lot more volume, right? Now, when you start decreasing the pressure again, that pressure can be decreased quite a long way before suddenly that alveolus collapse, boom, and then goes right back to point A. Now, if we convert this into looking at the entire lung, we find that if we increase the pressure in the lung, and then we hit a certain point, we call that point the lower inflection point, suddenly you need a lot less pressure to increase the volume in your lung. And if you increase that pressure to a point, suddenly then, well, not suddenly, as it happens, the lung will start to over distend, and you suddenly will not be able to increase your volume much more. And that's the point where you kind of want to back off, right? And as you back off with your pressure, you get to a point where the lung will collapse again. Where we want to oscillate patients is above this point. You want to keep that mean airway pressure right above this point where the airway collapses. And how do we go out practically doing this? Well, one way of doing it is by initiating high frequency oscillation and then recruiting the lung in a stepwise manner by increasing the mean airway pressure every 2 to 3 centimeters until we reach a target saturation with decreasing FiO2. And that's our critical opening pressure. And then we continue. Then we just push it a bit further. We continue to distend that lung up to a point where we can no longer get an improvement in our SATs targeting by reducing FiO2. And then we come back. Then we pull back and we find that critical closing pressure. And once we find it, we can re-recruit the lung and then step back and go to that optimal mean airway pressure. So setting the map is all about finding, that's literally about finding the sweet spot. And when you once you've recruited the lung and found this optimal pressure, it's about time to do a chest X-ray and make sure that you're not over distending this lung, and that would be prudent. But it's important to also realize that your map can affect your tidal volume, so that the tidal volumes that you achieve will obviously then affect your CO2 washout. And as your lung starts to improve, that spot of the sweet spot might actually move upwards on the lung. So you might actually be over distending. So it's important to wean as you go on. So the map is about finding that balance, that optimal distending pressure, where you get the best benefit without the over distension and without the atelectasis. If you over distend, you risk volutrauma, because at the top end of that curve the oscillatory volumes can reach the point where trauma can occur. But if you go too low, then you risk atelectasis, and you risk low tidal volumes causing atelic trauma and closure of the alveoli, and you get thick secretions, and you may need to do lots of suctioning to get rid of that thick secretions. And finding that balance is important. So when you wean, it would be prudent to start weaning only once your FiO2 is below 30%, and then you need to wean in a slow incremental decrease in mean airway pressure. Okay, that's about setting the mean airway pressure. And what amplitude you set up. Well, if you're starting at a hertz of 10, then it's a good guesstimate to start your amplitude at about 1.5 times PIP minus P. So, for instance, if your pressures that you're using are about 25/7, so a good place would be then to start on your delta P is 27 to 30. If your frequency is going to be higher than 10, then you might need a slightly higher delta P, and if your frequency is going to be less than 10, you might need a lower delta P. The important thing to do, the big important thing to do once you set these, is to observe the wobble that the patient starts wobbling, or you want to call it the jiggle or the wiggle. I don't know. There's different words being used. I just call it the wobble. And that wobble is important to observe, that it's not over vigorous and it's not dampened. And then also the ventilators allow us now to monitor the tidal volumes. Now remember that I mentioned the tidal volumes that you need are more or less depending on heart frequency that you use. And this graph shows not only the ideal tidal volumes essentially for different frequencies, but if you had to use those frequencies in different weight categories, what the DCO2 is that you would try and target. And if you target the DCO2 of about 50 to 40 to 60 moles per second, so moles squared per sec, moles per second per what they call now again, moles per second per kilogram. Then you will find that you'll find that you will be able to get a sweet spot of washing out your CO2 at that dCO2, and the idea would then be to target that dCO2. Now, what frequency do we choose? Now, remember we talked about frequency, and we're talking about it again. The best frequency to use is the highest frequency that you can use, because with higher frequency you get less barriers to flow. And in neonates, we talk about the corner frequency of a lung system, which is the point in the respiratory system where the energy flowing through that system starts to be reduced rather than just passing through it. Now, the corner frequency is related to the compliance and the resistance of a system. And in neonates, that corner frequency is below the ideal resonance frequency that we often talk about. So looking at this first graph, right, you see that the first figure plots the time constant of a lung against corner frequency. And the longer the time constant, the lower the frequency required. But the shorter the time constant, and this is where the kind of lungs with hyaline membrane disease, the stiffer lungs, they would need a slightly higher frequency. And that's shown here as well. The corner frequency, as I mentioned, is the point where energy flowing through the system starts to be reduced rather than just passing through it. So that's the ideal frequency to use. And in a healthy lung, that would be around about 10. But in a lung with high resistance and low compliance, like the hyaline membrane disease lung, you may be looking at frequencies above 10. In lungs with severe airway resistance, like lungs with severe pulmonary interstitial emphysema, you may want to use lower frequencies. And so this graph this table rather is a good indication of starting frequencies for various conditions that one might encounter in the neonatal unit. You'll note that the frequencies for hyaline membrane disease are starting at about 11.5 upwards to 15, and then the other conditions that we commonly see in the NICU, meconium aspiration, for instance, have a range between 6 and 11. So different frequencies for different size patients with different lung conditions. Okay, so now we're on to the when. When should we use high frequency oscillation? Should we use it for rescue? Should we use it for elective ventilation? Which patients? So the reality is, high frequency has been successfully utilized for the last 20 years and more in either elective or rescue in hyaline membrane disease and in other non-homogeneous lung conditions in the newborns. But unfortunately, the evidence from the meta-analyses and the systemic reviews of HFO trials hasn't really helped us to show that benefit. And I first want to talk about the Cochrane Review 2009. It's old already, but it hasn't been updated because there haven't been more trials looking at this that looked at is HFO better than conventional ventilation in term babies. And essentially, there were only 2 trials that they could find and could pull the data from. And the one trial used oscillation as rescue and the other as elective, and both had 81 patients in them. And in all of the outcomes, there was no difference in any of the outcomes of mortality or pulmonary air leak and all the rest of the main outcomes that were looked at. So the outcomes were similar, and it was very difficult to draw any conclusions from these studies due to the varied pathologies involved in these term patients and the interventions that were actually used. And then some commentators suggested that, you know, the reasons why no difference was shown could be around the timing of the commencement, and because actually some babies will just get better quickly regardless of what mode of ventilation that you use. And so there were also some concerns about the clinical staff in these trials and whether they actually understood how high frequency ventilation should work. So lots of questions about these trials, and so the meta-analysis for term and near-term infants with severe pulmonary dysfunction doesn't help us at all. What about preterm babies? So with preterm babies with acute pulmonary dysfunction, there were a lot more trials that could be looked at and a lot more infants. And essentially, the meta-analysis from the Cochrane library from 2015 looked at elective high-frequency oscillation versus conventional ventilation. And there were about 4,000 infants in this who all got ventilated early in their life, around about 12 hours of life. Unfortunately, the data here also did not really help us very much, because there was no difference between the two for mortality or for other major outcomes, including intracranial injury. However, for pulmonary air leak, it favored conventional ventilation. And for chronic lung disease in survivors, it favored high frequency oscillation ventilation. But these findings were very inconsistent. So again, the authors of this review were unable to actually give guidance as to which of the modalities were better. But they did highlight some of the issues in this research. But one of the issues were, well, some of the issues were that this really long time period over which the trials had been performed, and of about 25 years, and technology really has moved on in 25 years. And not only that, the way that obstetrics and neonatology has been practiced has changed in 25 years, and these might have influenced the conditions that they were studying, like respiratory distress and PPD. So you know that played a role. The other things that were highlighted were that in these trials there were so many inconsistent strategies that you couldn't just compare apples with apples. Not everybody followed the same high volume recruitment and FiO2 target strategies. Some didn't even do any recruitment or have any targets, FiO2 targets. So yeah, again, couldn't really compare them. Can't compare apples with apples. And then of course, the differing patient profiles in the early trials, they had much more mature babies. They had babies over 2 kilograms. And in the later trials, the babies were less than 30 weeks and less than 1,200 grams. So, you know, it's, again, patient profile, not very easy to compare. And then the other major problem was that in the early trials, the machines could not even measure the tidal volume. So there were concerns that some of the trials, they may have been using tidal volumes that were larger than the dead space. So essentially, that would have been conventional ventilation, just given at a very rapid rate. And so there are major concerns in terms of using this data, and that's the reason why there isn't any concrete guidance out of these concrete reviews. So which patients, right? Still, HFO, we're using it in neonatal medicine, and it's been firmly rooted and cemented, especially to treat homogeneous disease, babies with high limb disease, with a failure of conventional ventilation. These are the ones that we go for rescue HFLV, and especially patients where you start using high ventilator peak pressures and high tidal volumes and high respiratory rates, and as shown in this table below over here. In inhomogeneous or non-homogeneous rather lung conditions that we have in the neonatal unit, pneumonia, hyperplasia, congenital diaphragmatic hernia, and the rest, there is also a role for high frequency oscillation, and that role is to oxygenate and ventilate effectively, allowing the injured areas to heal, while at the same time avoiding new injury and further injury to the healthy lungs. And this, of course, can be challenging when the lung disease isn't uniform, but putting the areas with high compliance of at risk of overdistension and volume trauma, but the judicious use of tidal volumes and your amplitudes play a major role here. Then there's conditions like persistent pulmonary hypertension, where the focus should be on managing the underlying condition and optimizing the cardiopulmonary status. But we know also that when it comes to using inhaled nitric oxide, often lowering the mean airway, rather than put it like this, using inhaled nitric oxide and high frequency oscillation ventilation together is of benefit better than either modality on its own. So there is a role for high frequency in PPHN, but having said that, you've got to manage the underlying condition, and you've got to manage the underlying lung disease and recruit some of the focal atelectasis. But often lowering the mean airway pressure in patients with PPHN can have a more beneficial effect on the cardiopulmonary status, and you shouldn't just go for high maps on these patients. So yeah, so it requires some good titration of the mean airway pressure. When it comes to monitoring these patients, careful monitoring is very important. I can't stress enough how useful the ventilator monitors are in managing. And the older ventilators never gave us any of this data. We couldn't see what delta P we were achieving. We couldn't see what tidal volumes or the DCO2. We couldn't see any of those things on the older ventilators. The new ones are so much better in that aspect. And then, of course, monitoring the patients is very important, especially we find that the non-invasive transcutaneous PCO2 aspect to be extremely helpful, and I can't stress that enough. That's when you're monitoring these patients, you can see that the CO2 goes up immediately. You don't have to wait and do a blood gas, and you can adjust the ventilation, or you can attend to whatever the problem is, and of course get stable CO2s. Of course, there are other parameters that you would also measure, as well as getting chest X-rays. It's important that one looks at all of the monitoring, because especially around tidal volumes, because small changes in tidal volumes can have significant effects on the carbon dioxide exchange, especially as the lung and the circuit mechanics change from moment to moment. And yeah, and going forward, one has to monitor for complications. And in most cases, high frequency improves the critical respiratory condition that you've got, or at least temporarily. But of course, complications do come, and must be aware of them. And when it comes to failure, we've often found that failure is a result of using the inappropriate strategy. Now, I get my colleagues often telling me, oh, the patient didn't like the oscillator. It's not the patient didn't like the oscillator. You just haven't applied the correct strategy for that patient. And it's important to fully consider the patient's disease, the ventilator's ability, and the interactions between the two. So the inappropriate strategy can lead to like rapid worsening of the patient's condition. And it's important to remember that not all patients are going to respond as well to high frequency oscillation. The patient with homogeneous disease will respond much better than the patient with non-homogeneous disease, like a congenital diaphragmatic hernia or PPHN. These respond much poorer than, for instance, higher membrane disease. The other thing is to be able to early identify those patients that have failure. So we're talking about patients with persistently high oxygen or mean airway pressures, and then consider other alternative therapies. For instance, nitric oxide if you have a patient with PPHN, and if you're lucky enough to have ECMO and the patient is appropriate for that, then that's what you work towards. Other complications that we often see with oscillation is patients that are irritated. Sometimes it has to do with the sedation, and patients are not appropriately sedated. And so, that needs attention. Secretions are something we often see, and attention needs to be provided to the humidification systems in order to make sure that the humidification is adequate and that there's less secretions built up, because all those secretions block the small airways and eventually cause tidal volumes to be reduced. And important also to when you are considering suction, to consider inline suction so that one doesn't have to disconnect the ventilator from the patient in order to suction these patients. Another concern that we've got around high frequency oscillation is that sometimes when we're using high maps that we may be causing a decreased cardiac output. And so what we specifically need to do is to review the patient and review the mean airway pressures that we're giving, and sometimes you have to cut back and avoid over distension. And if you need to address giving the patient blood or giving the patient some pressors for the myocardial contractility. But yeah, these are one of the things that we often encounter, and just decreasing the mean airway pressure may actually improve the system completely. Okay, next slide. Okay, now let's move on to something completely different. Not completely different, but more about where we're going with ventilators and ventilation now. So, when our first ventilators essentially were not equipped with any sensors. They didn't tell us anything. We set settings into the ventilator and we watched the patient being ventilated, and we got some feedback from the patient, and then we went back and we adjusted the settings on the patient or on the ventilator. And then mechanical ventilators got a bit clever, and they started having sensors and allowed us to look at loops and things, and using that we could then make further adjustments to our ventilation. So we got feedback from both the patient and the ventilator. But now we are in an era where ventilation is going smart. Let's put it like that. Almost artificially intelligent, but not exactly, but almost. Where the mechanical ventilators monitor the condition of the patient and then automatically adjust the ventilatory parameters based on what the patient's needs are. Of course, the clinician sets in what those needs are, so it's not smart, or it's not artificial intelligence per se, but it is very smart. And here we're talking about volume guarantee ventilation. is basically where we have built-in computer algorithms to control aspects of the ventilation of the patient. And we've been using volume guarantee ventilation successfully in our unit for close to 8 years now. And essentially, volume guarantee ventilation gives you advantages of volume control and pressure control all rolled into one. It allows you to moment to moment keep a look on your look at your tidal volumes and then adjust your pressures in order to titrate that tidal volume to where you need it to be. And we've got it with conventional ventilation, and we have lots of experience with that, with conventional ventilation and volume guarantee. As I say, for the last 8 years, we've been using that. But now it seems that the machines that we've got also have the capability to do volume guarantee in high frequency oscillation ventilation. And our experience with this is less than with conventional ventilation, but the evidence for this is piling up, and it is something that we need to consider in the future. So why high frequency oscillation ventilation? Volume guarantee, or HFO-VG, I'm going to say. I've already said that our tidal volume is very important in ventilation of the newborn and in oscillation, especially now also. And what happens when you oscillate the patient is that there's these variations that you get in your tidal volume as a result of the secretions in the tube or changes in the lung dynamics. And if you've ever watched the ventilator and you set your delta P and you set your frequency and set everything and you just watch, and then watch this little VTHF monitor in this ventilator, you'll see that the VTHF changes every so often. It changes, and it will get less, it will get more, and as you get less, you see that your patient doesn't wobble as well anymore, and you may need to give your patient a suction, or if the patient's getting better, then suddenly you see your VTHF is now really big. So it changes from moment to moment, and those changes in your VTHF can bring about variations in your PCO2, and if you're not careful, can cause hypocarbia or hypocarbia. And of course, hypocarbia we know is bad. It changes your pH level, and it changes your cerebral blood flow. So we want to keep it stable, right? And we want to keep it in the permissive hypercapnia range. So HFO-VG allows us to do this by fixing our VTHF. Now, how does it do this? So essentially what you do is you set the volume guarantee target, the volume target that you want, appropriate to your selected frequency for oscillation. So you do this by, as you normally would put the patient on ventilator, you'd start with adjusting the amplitude and the frequency on your initial setup of the patient, and until you achieve what you desire, your desired tidal volume, your desired DCO2, again, DCO2 comes up, and then you'll check your patient's PCO2, PaCO2, you'll do a blood gas, and you'll have a look and say, are you happy now? If you're happy, then that's what you stick with, or you will change your amplitude, or that's what you would normally do. You'd normally change your amplitude or your frequency to change your PCO2. Okay, but in this case, you would get to the point where you are happy with your PCO2, and then you look and see, well, how much tidal volume am I delivering? And then you'd set that tidal volume into the machine as what you want. And you hand over control of the amplitude to the ventilator, obviously within your user specified limits, by selecting the high frequency oscillation ventilation button on the control panel, and setting the delta P. So the only thing that the ventilator does is change the delta P according to the tidal volume that's being achieved. The frequency and the IE ratio will remain constant at whatever you've set it at. So, so that's important to remember. The only thing that it changes is your delta P. Okay. Does it work? Well, as I said, in conventional ventilation, without a doubt, volume guarantee has shown improved outcomes in many, many studies. And the in HFO or VG, the evidence is still accumulating. There isn't a lot, but it looks good. Whatever there is, looks really good from both the lab and from the bedside. And from the clinical studies, we can see that when VG is used, there's more stable ventilation and there's better control of PCO2. And Gonzalez showed that using in a feasibility study, they used very high frequencies with very low VTHF in HFO with VG, and was able to produce similar PCO2s when using a targeted DCO2 model. And Beltecki more recently also showed or rather reported their observational experience using VTHF in 17 infants, and how most of the time you could get away with a very small tidal volume when controlled with HFO VG. And you really needed more volumes of more than 2.5 moles per kilogram. So coming back, does frequency matter? This frequency keeps popping up. So I'm going to take you back for the people with experience with oscillation. When you normally drop your frequency, you're doing it to increase your tidal volume and decrease your CO2. You struggle with the patient, the CO2 is high, you've already increased the amplitude. What else can we do? We drop the frequency, right? But in HFO VG, when you drop your frequency, something else happens because your tidal volume is fixed. Changing your frequency will also change your delta P, because you're trying to achieve the same tidal volume that you always have, because that's what you asked for. Now, if you suddenly change your frequency, what's going to change? Your tidal volume is going to stay the same, but your amplitude is going to change. And if you increase it, your ventilator will increase your delta P to keep that tidal volume fixed. But remember, DCO2 over here, frequency versus tidal volume squared. Now, if you increase your frequency, here your DCO2 is going to increase. Remember, your tidal volume is fixed. This is no longer an issue. That's fixed. In volume guarantee, you increase your frequency, your DCO2 is going to increase as well. And now that means your CO2 is going to wash out, and vice versa. And animal studies by Mukherjee and Sanchez Luna have confirmed this, showing that there's this independent relationship to PCO2 in high frequency. The other thing that Sanchez Luna and his group showed was that when you use smaller tidal volumes and at a higher hertz with similar PCO2s in a lung model or the piglet lung model, we're able to show that you actually have less inflammation. So your frequency does matter. So if you have high frequency, you can have less injury. And when you change your frequency, remember you're also changing your DCO2, which will change your tidal volume, or rather your CO2 washout. So you may actually need smaller tidal volume. So I'm going to leave you with my last slide now before we take questions. And the last slide is the study. It's an observational and single center study, which I want to talk about. And what is it's not a trial, but it's an observational study. But what it's got going for it is relatively large numbers, and the fact that essentially experts were using the ventilators here, so they knew what they were doing. So this study compared the outcomes in small preterm ventilated infants within the first few days of life in 2 different periods which were actually quite reasonably recent. We're talking about periods of between 2012 and 2013, and 2016 and 2017. And during these two periods, they were looking at patients with 32 weeks gestation and less. We were looking at patients that had mechanical ventilation for more than an hour in the first 3 days of life. Of course, they excluded outborns and patients with congenital malformations. But what they did differently between the two time periods is the way that they approached, or rather the bundle that they had looking after patients who were preterm that required ventilation. And what they would do is they'd use the same surfactant. When they used conventional ventilation, they used the same lung protective strategies. And when they did oscillation, they would use the same recruitment, high MAP, low FiO2 strategy. But what they did differently was in 2016 to 2017, they used volume guarantee in their high frequency oscillation mode. And instead of using Insure for giving surfactant, they used the less invasive method now, less invasive surfactant administration, where the patients are not intubated. They just use a thin catheter to pass surfactant. And the other thing that they did was they started introducing synchronized non-invasive synchronized non-invasive positive pressure ventilation for rescue for patients that were failing CPAP. So this is not what they had there. So this bundle was very different only in volume guarantee and the way the surfactant was given. And they had introduced this, but not a lot. And what we see here is the 2012 cohort. You see the 2016 to 2017 cohort. And you can see they were different in that they got the 2016 cohort didn't get Insure at all. Most of them, in fact, got Lisa. The other things that were different about them is that they were intubated for more than an hour, more often in the 2012 to 2013 cohort when they were given surfactant. So, and of course, yes, there was more synchronized non-invasive positive pressure ventilation used in the 2016 model. But the outcomes I want to look at is the high frequency oscillative ventilation on day 3 of life. And we find that statistically significant differences in how many patients were ventilated with oscillation on day 3 of life between the two cohorts, with almost 80% of the patients requiring ventilation being oscillated on day 3 versus 56% in the earlier cohort. And then the outcomes in terms of survival-free PPD was much better in the second cohort, as well as for severe grades of PPD. So BPD in total and severe grades of BPD. And then when we looked at the way that they actually ventilated patients in terms of the oscillation, we find differences in the frequency that they used in the second cohort, or the second time period. Their frequencies were much higher, using frequencies of 15 versus frequencies of around 10 in the earlier cohort. And the tidal volumes were much smaller. So those are the differences that one can easily pick out of this paper. And I just wanted to say that essentially, I don't think it's just one specific thing that we do that improves the outcomes in terms of PPD, but rather every little incremental thing that we do to change the way we manage our babies, that all have a cumulative effect. And I think that oscillation with VG is one of those, and Lisa for sure is definitely one of those. If we're looking to improve our outcomes, we should be considering all of these little changes: smaller tidal volumes, Lisa, volume guarantee, in our armament of therapeutic modalities. And I want to leave you with that, because perhaps less is more, and we can take questions now. Thank you very much.
Thank you, Dr. Dule, for that very informative presentation. So to all the attendees, if you do have any questions, please remember to go and type in your questions into the question box using the GoToWebinar tool on the right-hand side of your screen. So Dr. Dule, there is one question at the moment. Thank you for an amazing presentation. Can you please repeat the slide on how to adjust settings of HFO with volume guarantee?
Sure, can definitely do that. If I get my slides back, there we go. HFO with volume guarantee. Where are we? There we go. So, what are we talking about? We're talking about setting up high frequency oscillation volume guarantee by first setting up high frequency oscillation. So you would do it as you normally do. You set your patient up with your amplitude that you want, your correct frequency that you want to use for that specific patient. You look for the wiggle, and you look at your tidal volumes and your DCO2s. Again, try and target the DCO2 of 40 to 60 moles squared per kilogram squared per second. You can see how much of a tongue twister is that. That's why I struggled with that earlier. But essentially 40 to 60 per kilogram squared. Okay, and then you check your normal parameters, what you normally would do, your PCO2, you check. And if you're happy with that tidal volume, if you're happy with that CO2 that you've got, if you're happy with the way the patient's wobbling, then you turn on high frequency oscillation ventilation with volume guarantee, and you set in the tidal volume that you are currently giving. Now, it will be between 1.5 and 2.5 moles per kilo, obviously depending on the frequency that you're using. And again, the higher the frequency, I think the better, because you get lower tidal volume with that. And then you set that volume into the machine, and you set how much leeway you want to give the device. So you'll set a delta P max, and that delta P max on the oscillator is generally about 10 to 15 above what the current delta P is. That gives the machine some time to give some leeway to adjust upwards if it needs to be, but not so much that you won't be aware of changes in the patient's condition. Essentially without you knowing about it. And again, the machine only adjusts the delta P. It doesn't adjust the frequency or the IEE ratio. That remains constant at whatever you set. And remember, your DCO2 is related to your frequency. So if you're in volume guarantee mode and you change your frequency, it's going to change your DCO2, and that's going to change your CO2 washout. So yeah, you have to keep that in mind. And it's a whole mindset change from how you normally would do it. And you really have to grapple with it first before you actually do it.
Okay, thank you. So there is another one for me to answer. Thanks for the excellent talk. Will the slides be made available to download? So the entire webinar is being recorded, and the recording will be sent out to all the attendees in due course. So this will happen probably sometime next week. or the week after, that the recording will be sent out to all the attendees. So thank you for that question. All right, so just want to go to the next question. I have seen a big problem with CO2 retention due to improper usage of the humidifier.
What's the question?
That's basically the, yeah. more a
Okay.
statement, I would guess.
More, yeah. So yes, I mean, so humidifier needs to be needs to be managed. It needs to be filled appropriately to the correct level, but in order to get the most power out of it. And then you have to make sure that that you don't have a lot of rain out or condensation in your humidifier or in your patient circuit, because that will affect your tidal volumes. It'll affect your oscillation. And essentially, that's actually one of the things we struggle with a lot in our unit, just keeping that constantly in check. But yeah, it's you know, this is not something you just sit and walk away. It needs constant monitoring from both the patient side and the equipment side. Yeah.
So if I may just from a Dräger perspective add on to that answer. So please remember that the humidifying chamber has what we call a compressible volume. And during the checking of the device, and specifically the circuit check of the device, if you're using one of the baby log devices, that the circuit check is basically null and void until we're going to actually ventilate the patient. The reason that I say it's null and void is because if you do a circuit check with a dry circuit, that means that the humidification chamber is empty and your compressible volume is very high in that chamber. And that means that the ventilator is determining the compliance and resistance of the circuitry system with a high compressible volume. The minute we're going to actually start ventilating, we then spike the vacuolator and allow the water to run into the chamber and hopefully maintain the maximum fill level. And this addition of water into the actual chamber changes the compressible volume within the circuitry because the humidifier is part of the circuit. So to avoid your CO2 retention and all the changes that we see as a result of the humidifier, it is imperative, and especially with neonatal ventilation, and even more especially with high frequency oscillation, is that the circuit check must be done with water in the humidifier at the maximum fill line. And once that breathing circuit check has been done, then and the aim is to obviously throughout high frequency oscillation or even conventional ventilation is to constantly maintain that water level. The minute the water level changes, you will see a change in the compressible volume and thus changes in the tidal volume that is getting to the patient. So this is absolutely crucial to neonatal ventilation as well as high frequency oscillation. So I hope that answers the question with regard to the humidifier and CO2 retention. So, Dr. Jule, the next question, it doesn't make sense how increasing frequency decreases tidal volume. My understanding is that the higher the frequency, the more tidal volume you get because you have more time and more spaces under the graph, therefore increasing the tidal volume. Do you mind explaining this concept? Thanks.
I think he just explained it himself, but in whoever the question asked the question, but in reverse actually. So increasing your frequency So if you increase, let's just take round numbers like a hertz of 10. Okay, in a hertz of 10, you've got 600 cycles per second, per minute. If you increase your hertz to 15, now suddenly you've got 900 cycles per minute. In order to get that cycles done in that minute, what's got to change? Amount of time per cycle. So if your time per cycle is now less in higher frequencies, that means your area under the curve is also less. And there just isn't enough time to develop a high tidal volume. I hope that answers the question.
Absolutely. So the next question, again, with regards to the humidifier, should the humidifier be switched off? So I think this might be in relation to my response with the fact that it needs to be tested, the circuit needs to be tested with the humidifier filled. So no, that the humidifier does not need to be on during the circuit check. But I mean, if you're going to start, if you've filled the humidifying unit with water, it means that you are going to start ventilating. So it would probably be quite a good idea to already switch the humidifier on. So having the humidifier switched on and off has less of an effect on the achieved tidal volumes and compressible volume within the chamber. So it does not need to be switched on, but if you're going to start with high frequency oscillation or conventional ventilation, it would be a good idea to switch it on, that it can heat up so long. So another question for you,
yeah.
Yes?
No, I just want to add, it certainly needs to be on when you're busy oscillating the infant.
Absolutely.
Yeah, so just to add that.
No, absolutely. But it's not a prerequisite for the test, the circuit test.
For the checking, yeah.
Yeah, absolutely. So is it safe to switch the humidifier off? Because I have noticed when switching it off, it makes a bigger difference.
Turning the humidifier off will make a bigger difference to what? To the oscillation, to the tidal volume. It should, you know, okay, here's when you ventilating infants, your humidifier needs to remain on. If you're not having it on, it means you're going to be delivering dry, cold air to the infant's lungs, which the only thing that's going to do is going to cause trauma by increasing the secretions and by causing, you know, essentially what we call the rheotrauma as a result of the flow of air, which is basically going to be cold. And yeah, it's not a good idea to switch your humidifier off.
I have to agree with you 150% there. So just to add on to that question, the person asking the question said it makes a big difference to the CO2 when they switch it off. But I have to reiterate with you, Dr. Dule, once again, that at no time should any patient, doesn't matter in what way or manner they are being ventilated, no patient should receive cold, dry gas from the device. So there should be some form of humidification and filtration going on during ventilation. I'm not sure if you agree with me, Dr. Dule.
No, absolutely, absolutely, absolutely.
Okay.
Especially with, we're talking about preterm babies with really small diameter airways, and little bits of secretions and plugs going to affect your ventilation significantly. And it's important, it's really important that it's humidified.
Absolutely. So thank you for that. I don't see any more questions coming through at the moment. So We'll give another minute or so just to see if there are any more questions coming through. But that does seem to be it for the evening. And I think we did it in good time.
Yeah, I mean, it's a lot of concepts to cover, and I mean, there is a lot of science here. So I'm glad we could cover it, and I'm always happy to take questions by email. That's also fine.
Okay, so there is another question that has just popped up. Do you suggest dual or single heated circuits?
Okay, that's a very good question. We've used both. We've used dual limb heated circuits, and we've used the single limb heated circuits. And we find that the dual limb heated circuits, even though both limbs heat up, they can still produce some condensation, especially if your temperature probe is not positioned in an ideal way, or if the ventilator is in a cold, drafty environment. So condensation still occurs, although to a less extent with the single limb heated circuit. But we have used both, and we've ventilated successfully with both.
Perfect, thank you
The
for
single limb
that.
heated circuit just requires a bit more nursing.
Absolutely. So because there's often a lot more rain out in the circuit.
Yeah.
Absolutely. Thank you for that. So please, if there are any more questions, if you could maybe just raise your hand that you are still busy typing so that I don't end off and then we miss your question. But we have a few more minutes. So if there are any more questions, you are welcome to type them into the question function. I don't see anything, and I don't see anybody's hands going up to indicate that they are still perhaps typing. So with that, then I would like to close off the webinar for this evening, and just a huge thank you to you, Dr. Dule, for a very informative and information-packed presentation this evening. I would also like to thank you for taking the time out of your busy schedule to be able to present this webinar for us today. We are really very grateful for your input into today. I would also like to thank all the attendees of the webinar, and please don't forget, as I close off the webinar, there will be a feedback survey. Please could you take a minute or two of your time just to give us your feedback on the webinar. And Dr. Dule, so I do see something has come through. Dr. Dule's email address, please.
Sure, it's actually available on the UCT website, but I'll give it to you. It's yasin.joolay@uct.ac.za.
So perfect. So thank you for that. And the person asking the question has also said thank you. So thank you once again, Dr. Dule, and to the attendees. I'd like to thank you. Please remember to complete the feedback survey as I close off the webinar this evening, and then also just to indicate if you would like in the future to have a virtual practical session, which we will then do using our BabyLog VN family devices. So with that, I'd like to thank everybody once again. Have a good evening, and we will send you the recording in due course. Thank you and good night. Thank you, Dr. Dule.
Thank you. Are they off?
They're busy logging off, yes.
Okay.
If you give another minute or two.
Okay. So I can